Good afternoon. My name is Laura Young, and I am the program manager for the CPAN program at UT Health Science Center in Tyler. Over the next hour, we'll be presenting, Dr. Johnson will be presenting clinical pearls, treating autism spectrum disorder in children and adolescents. I'm going to go ahead and turn it over to Dr. Johnson to go ahead and begin her pulling up her slides, but I'd like to introduce you to her right now. Dr. Taya Johnson is a native of Louisville, Kentucky, where she completed her undergraduate and medical school education at the University of Louisville. She completed her adult psychiatry residency at the University of Miami, her child and adolescent psychiatry fellowship at the University of Louisville, and then her forensic psychiatry fellowship training at the University of Cincinnati. She's currently board certified by the American Board of Psychiatry and Neurology in Psychiatry, the Child and Adolescent Psychiatry, and Forensic Psychiatry. Dr. Johnson worked in private practice in Louisville for 2 years, where she treated children, adolescents, and young adults with various mental illnesses. She remains a clinical assistant professor gratis at the University of Louisville's Department of Pediatrics and is a past member of the University of Louisville School of Medicine's Admissions Committee. Dr. Johnson relocated to Tyler in 2020. She is an assistant professor of medicine in the Department of Psychiatry and Behavioral Medicine here at UT Health Science Center in Tyler. As one of the child and adolescent psychiatrists for the CPAN program, Dr. Johnson enjoys educating PCPs about treating mental illnesses in children and adolescents. Her specialty interests include treating children and adolescents and young adults with various psychiatric illnesses, especially within the minority populations, and conducting evaluations specifically related to forensic psychiatry. Outside of work, she loves dancing, virtual boot camp classes, watching college basketball, and really good food. So please join me in welcoming Dr. Taya Johnson today.
All right, I'm trying to pull this up.
All right.
Laura, can you let me, what screen is showing? Is it the correct screen?
You're good.
All righty. Well, thank you everyone for attending this talk. This is the third installment of my Clinical Pearls for Primary Care series, talking about treating autism spectrum disorder in children and adolescents. So the goals and objectives for this presentation is that participants should have increased information to recognize the presentation of autism spectrum disorder symptoms in children and adolescents, provide examples of how to screen and assess for autism spectrum disorder in children and adolescents, and then describe the different treatment options to consider when treating children and adolescents diagnosed with autism spectrum disorders. Discuss autism. And the DSM-5 clinical presentation, when we talk about autism spectrum disorder, so previously that used to include early infantile autism, childhood autism, autism, high functioning autism, atypical autism, pervasive developmental disorders not otherwise specified, childhood disintegrative disorder, and Asperger's disorder. So DSM-5 got rid of all of those different names for autism spectrum disorder and just called them all autism spectrum disorder, and then you label the diagnosis or the severity of symptoms based on a level of symptomatology. So the clinical presentation of DSM-5 includes the persistent deficits in social communication and interaction, and then repetitive restrictive patterns and repetitive thoughts in children. And so we'll talk about first the persistent deficits in social communication and interaction. That's the first part. And then the second part is the restrictive patterns within children with autism. So when we talk about persistent deficits in social communication and interaction, we are talking about social emotional reciprocity deficits, where children show little to no initiation of social interaction, no sharing of emotions between the patient and someone else, reduced or absent imitation of others' behaviors, And then existing language is one-sided, lacks social reciprocity, and is used to request and label rather than comment, share feelings, or converse. So they may just only, speak with one or two word phrases, and don't really, it's not really a spontaneous back and forth conversation. You will also notice deficits in nonverbal communicative behaviors used for social interaction. So they can have absent, reduced, or atypical use of eye contact compared to cultural norms. And we have to say compared to cultural norms, because in certain cultures, eye contact in certain situations may not be considered culturally appropriate. They may have reduced or atypical use of gestures, facial expressions, body orientation, or speech imitation. They may have impaired joint attention, so lack of pointing or showing or bringing an object to mom or dad or others to share an interest, or they don't follow when someone is pointing or showing their eye gaze, like saying, hey, look over there, and they don't look when you point. That's an early feature of autism spectrum disorders. And then they fail to use expressive gestures spontaneously in communication. Now, deficits in developing, they also have deficits in developing, maintaining, and understanding relationships. So there may be an absent, reduced, or atypical social interest. They may show a lack of shared social play and imagination, especially in young children. They may insist on playing by very fixed rules. So like say they play a game, but they only play the game the way they want to play the game. They will not allow for any differences to be introduced into the way that the game is played. So they're very, very restricted in that sense. They prefer solitary activities, or you may notice that they interact with much younger people or much older people. I had one kiddo that was diagnosed with autism, and he was a 14-year-old boy, and dad wasn't able to understand why he liked playing with the 6, 7, 8-year-old kids in the neighborhood versus playing with kids his own age. And dad just really wasn't understanding the concept of he has autism, and this is a sign of that. But he really loved playing with those much younger kiddos in his neighborhood. And then they may have a desire to make friends, but they don't really understand what friendship is. So they don't have a realistic idea of what a friendship is. So sometimes they will present to you, and they may say, such and such is my friend, and when you ask them why they are their friend, they may say something like, well, because they like what I like, or they do what I do, and it's not beyond that. Like, you can't get them to understand that it's kind of a reciprocal situation when you're dealing with friendships. So, like I said, there's two parts of autism. And so you have the deficits in social communication and interactions, and then you also have the second part, which is the restrictive, repetitive patterns of behaviors, interests, or activities. And they must be manifested by at least two of the following, currently or by history. And the previous with the social communication, that was also the same there, that you need at least two of those behaviors that I talked about currently or by history. So, they may not still have those symptoms, but they can have them in history. And it's for the restricted, repetitive patterns of behaviors, interests, or activities. So they may have stereotyped or repetitive motor movements and use of objects or speech. So they may have simple motor stereotypes such as hand flapping and finger flicking. They may have repetitive use of objects, so they line up toys, or they're always spinning coins. And then they may have repetitive speech, so what we call echolalia. So when you talk to them, you say, hi, how are you? They say, hi, how are you? You say, well, what are you doing? They say, what are you doing? And so they kind of are parroting back what you say. They may have insistence of sameness. They may be inflexible. They may have an inflexible adherence to routines, or they may have ritualized patterns of verbal and nonverbal behavior. And so they usually, when they have this insistence on sameness and inflexible adherence to routines, ritualized patterns of behavior, they may exhibit extreme distress with small changes in any of those things. They may have difficulties with transitions. That's usually a big one, like any kind of transition from, like, say they are going from at school, they may struggle with the transition from going from one class to another. So they may do better with just being in one classroom all day long, because they don't do well with transitioning between classrooms if the classrooms change. They may have rigid thinking patterns. And sometimes they have the need to eat the same food every day. That is usually a common complaint from parents, is that, I can't get them to eat anything else. I can't get them to try anything else. They only will eat, hot dogs, or they only will eat cheese, or, something like that. And it's like, we literally can't get them to eat anything else. They may also have highly restricted fixated interests that are abnormal in intensity of focus. So they may have a very strong attachment or preoccupation with unusual objects. I had one kiddo that loved rocks. Just any rock that he saw, he absolutely loved them, and was very strongly attached to these rocks. If you removed a rock from his hand, it was a complete meltdown, and just wanted to. All he cared about was rocks, 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 and rocks. He wanted books about rocks. Everything he wanted to do was rocks. And so they can have this strong attachment or preoccupation with unusual objects, and they can also have excessively circumscribed perseverative interest as well. So one kiddo that was not diagnosed with autism before I saw him, but I suspected autism, he actually was very, very perseverative on talking about Star Wars, like everything Star Wars. As he talked to me in one of the characters' voices, he would hum the theme song music throughout the appointment sessions. Every time he brought a toy in with him, it was something related to Star Wars. Everything for him was Star Wars. I could not get him to talk about anything else except for Star Wars. Anytime I tried to change the subject from Star Wars, we had a problem. And then children with autism may be hyper or hypo-reactive to sensory input, or have an unusual interest in sensory aspects of the environment. So they may be very indifferent to pain and temperature. They may have an adverse response to specific sounds and textures. They may have excessive smelling or touching of objects. I had one kid that just would love to smell his hands all day long. That's all he did, was smell his hands. He kept his hands in his face and smelled his hands all day long. I had another kiddo who, there's certain kind of fabrics that he could not wear on his body, or it would cause him to act out. And, mom figured that out once she figured out what was causing his behavior problems. And, she had to make changes with that and trying to figure out what fabrics did not bother him, but it was a specific type of fabric he could not handle. So that's another aspect of autism spectrum disorders. And so, like I was mentioning at the beginning, we no longer have, Asperger's disorders or high functioning autism. We don't talk about autism in that way anymore. We now give them severity levels. According to DSM-5, we do levels. So like level 3 means they require very substantial support. So they have severe deficits in social communication and severe, extreme difficulty coping with change related to the restrictive, repetitive behaviors. And then level 2 is they require substantial support. So they have marked deficits in social communication, but it's not, they still need a lot of support, but it's not to the level of level 3. And again, with the inflexibility. And then level 1 is where it requires report. So this would be more of a mild case of autism. If we have to think about how we previously used to think about it, level 1 would probably be where we would put our Asperger's kiddos, if we were using that nomenclature, that's where we would put those kids would be at level 1. So they require support, but it's not necessarily that they need this same amount of support as those with that are lower functioning. So the symptoms of autism must be present in the early developmental period. They may not manifest, though, until later in life when social demands may exceed the limited capacities, or they may have been able to mask their symptoms by learned strategies. So parents may not notice it, and I've seen it quite a few times as well, where I got a kiddo that's 10, 11, 12 that no one ever considered autism as a diagnosis in that child. But as they got older, the strategy that they learned to mask some of those symptoms that they had were now being unmasked, and we were seeing the symptoms come out. So, but then when the parents thought about it, once we discussed it, and the parents thought about it, like, yeah, these symptoms were present earlier in life. We just, didn't think of it like that. The symptoms also have to cause clinically significant impairment in social, occupational, or other important areas of current functioning. And then it's not better explained by intellectual disability or by global developmental delay. If it is better explained by those, then you diagnose those over autism. Now, for some clinical pearls. The symptoms of autism are typically recognized during the second year of life. Sometimes you can recognize those symptoms earlier than that if the developmental delays are very severe. And then sometimes you may not recognize the symptoms until later because the symptoms are more subtle. The diagnoses are most valid and reliable when you have multiple sources of information. So when we say multiple sources of information, we're talking about clinicians' observations, caregiver history, and self-report if possible. Of course, also input from teachers and anyone else who has interaction with the child. The more sources that you have, the better to help you come up with this diagnosis. Even when formal language skills are intact, the use of language for reciprocal social communication is impaired in autism, in the autism spectrum disorder. So they may, they may talk just fine. They develop, their language skills develop seemingly normal, but it's that reciprocal social communication that is impaired. So they can't have what we would call a normal conversation with back and forth talking. They can't, that's impaired. Preschool age children typically present with a marked lack of interest in others, failures of empathy, absent and severely delayed speech or communication, marked resistance to change, restricted interest, and stereotyped movements. So those first symptoms involved in delayed language development are accompanied by a lack of social interest and unusual social interactions, odd play patterns, and unusual communication patterns. With the common parental concerns, they usually, when parents think along the lines of autism, when they're coming to see you in your office, they're usually coming in for 3 different things. They notice a lack of language in the child, a lack of language development in the child. They notice inconsistent responsiveness in the child, and they come in thinking that maybe the child may be deaf because of their inability to communicate with language. There is actually typical for parents to report no period of normal development, or that there was a history of the child seeming too good and undemanding as an infant. So they may misinterpret the fact that the child does not need or seek social interaction as, oh, they're just a really good kid, or they're not demanding, they just sit there and they're fine just being by themselves, and they don't think of it as a problem until maybe they get a little bit older and they're, the parents notice other things that are different about their child. By school age, social and communication skills usually increase, but problems dealing with change and transitions and various self-stimulatory behaviors become more prominent. So in the school age kids, you're going to see them, they may talk more and try to have some kind of social interaction more, but they have a lot of problems with the change and transitions and self-stimulatory behaviors, such as head butting or hitting their head on the wall, or other kind of self-stimulatory behaviors they may have. The presence of speech by age 5 and the overall cognitive ability and IQ are the best predictors of prognosis. And so early detection and use of services improves long-term prognosis. And so it's very, very, very important to have early diagnosis and early detection, because the trajectory of how that child develops and how that child is able to function throughout life can change significantly depending on how early they are diagnosed and how soon they can get interventions. So for differential diagnosis, in order to diagnose autism, the DSM-5 symptoms must be present and other disorders must be adequately ruled out. And so you have a lot of other disorders that you need to rule out first. So specific developmental disorders, including language disorders. Those children with developmental language disorders usually point to show interest in objects and use conventional gestures to attempt to communicate with someone, but children with autism do not. So while you may say, okay, this child is having developmental problems as far as developing language skills, they still will show other signs of social communication and understanding of, shared eye gaze, point to communicate, things like that. Children in autism are not going to have that, show the shared eye gaze and the pointing to communicate. You need to rule out sensory impairments, especially deafness, because if a child is deaf, that is the reason why that they are not, able to communicate or able to learn language, because they can't hear to learn how to speak. So you need to rule out deafness. Reactive attachment disorder. So in reactive attachment disorder, there may be deficits in attachment and inappropriate social responsivity, but usually that improves after adequate caretaking is provided. Obsessive compulsive disorder. So OCD has a later onset than autism, and they're not typically asocial. And they don't have social or communicative impairments. They do have repetitive patterns of behavior with obsessive compulsive disorder, but that repetitive patterns of behavior are ego dystonic. So they don't want to do them and they don't like to do them, or they find doing those repetitive patterns of behavior distressing. Whereas with autism spectrum disorder, it's what we call ego syntonic. They don't mind that they are doing their restrictive pattern of behavior. In fact, they like doing it, and if they can't do their repetitive patterns of behavior, they're going to get angry. So that's the difference between OCD and autism spectrum disorder. Now, with intellectual disability, there's no discrepancy between the level of social communicative skills and other intellectual skills. Like if it's intellectual disability, if they are very low on the intellectual disability, they have a very low IQ, their social communicative skills are going to be at the same level as their IQ level. There's not going to be a difference. In autism with intellectual disability, the social communication and interaction are significantly impaired compared to the developmental level of their nonverbal skills. So there's going to be a difference. They'll have a certain IQ level, a lower IQ, but their communication, social interaction is significantly impaired, even once you consider their level of IQ, if they have autism with intellectual disability. Anxiety disorders, including selective mutism. So you'll have excessive worry, the need for reassurance, inability to relax. Feelings of self-consciousness is seen in both anxiety disorders and autism spectrum disorders, especially those who are higher functioning. But in anxiety disorders, you're not going to see that prominent social communicative impairments in those with anxiety disorders. And then children with anxiety disorders tend to develop social insight, which is not present in children with autism. And then another one to rule out is childhood onset schizophrenia. Can be very different difficult to differentiate between the two because both have social impairments and odd patterns of thinking, but those with autism rarely have delusions and hallucinations. So that's one thing that would make you think more along the lines of childhood onset schizophrenia versus autism spectrum disorder. But childhood onset schizophrenia is such a rare situation, you're probably not going to come in contact with that anyway. And then, of course, rule out other organic conditions. Now, comorbidities. There are many individuals with autism spectrum disorder have symptoms of psychiatric disorders, and it is complex to diagnose those additional disorders in autism spectrum disorders. Hyperactivity, obsessive compulsive events, self-injury, aggression, stereotypies, tics, affective symptoms, so mood symptoms can be present in those individuals with autism. Their affective symptoms include labile mood, inappropriate affect response, anxiety, depression, impairment in emotion regulation can cause over and under reactivity in those with autism. And then they frequently have issues with attention, especially if it's something that is not within their interest, their restrictive interest. They may struggle with attention. So you will see that in children with autism. And if a patient with autism meets criteria for autism and another psychiatric diagnosis, diagnose both of the disorders. Don't hold back on giving that child the additional diagnosis if they meet criteria for both. Go ahead and diagnose both. So as far as screening and assessment for autism spectrum disorders, developmental assessment of young children and the psychiatric assessment of all children should include questions about autism spectrum disorder symptomatology. So you should ask about the core symptoms of autism spectrum disorder, which include the social relatedness and the repetitive unusual behaviors, and then utilize some screening tools that have been developed. Now, some of the screening tools have to be completed by other clinicians. Some have to be completed by the clinician, and some have to be done by the primary caregiver. And those examples of those screening tools include the Autism Behavioral Checklist, the Childhood Autism Rating Scale 2, and the Ages and Stages Questionnaire. Now, if the screening is positive for significant autism spectrum disorder symptoms, you need to conduct a thorough diagnostic evaluation. That's going to include an interview with the family and the child. You're going to need to do review past records and history. So look at past and current educational and behavioral interventions, family history, relevant psychosocial issues. You're going to do a thorough developmental history. And then, carefully consider the DSM-5 criteria when you are conducting the history and examination. You should be examining the child's social interaction and restrictive repetitive behaviors. Usually you're going to be able to pick up on their deficits in social interaction, and you're probably going to see some type of sign of their restricted repetitive behaviors while they're in your office. So it may not be a thing of where you see it, you see them interacting with other children, but you will be able to see some of those signs as they interact with you, as they interact with their parents, as they, maybe playing with a toy that's in your office or something. You will be able to observe that. Assessment instruments have been developed, and they include the Autism Diagnostic Observation Schedule, or the ADOS, the Autism Diagnostic Interview, the ADI, and the Diagnostic Interview for Social and Communication Disorders, or the DISCO. Now, some of those instruments that I named require specific training to use, like specifically the ADOS. I know you have to be specifically trained in that and in giving that assessment tool and scoring it. Now, you also need to make sure you do a multidisciplinary assessment, so medical assessment, which may include a physical exam, hearing screen, genetic testing, excuse me, and other tests as indicated. If you need to do EEG or labs or anything like that. You need to do a psychological assessment, so assess cognitive ability and adaptive skills, and consider getting IQ testing if you think it's necessary. And then a communication assessment, so measure receptive and expressive vocabulary and language use. And you may need to utilize physical therapy and occupational therapy evaluations to evaluate sensory and motor difficulties. So clinical pearls. During the assessment, also consider possible comorbid diagnoses too. like we talked about, because children with autism can have other diagnoses. This is not just one diagnosis, then you can't diagnose anything else. So also think about, anxiety, depression, ADHD in these kids. Autism is a clinical diagnosis. So testing is not required to make a diagnosis. So the ADOS that I spoke of previously, not required to make a diagnosis, but they can help supplement your clinical judgment. So if you think, I think that this child has autism and I want to see, how they do on the ADOS. But even say you get them the ADOS and the ADOS does not, they don't score high enough to be diagnosed with autism by the ADOS. That doesn't mean you can't still diagnose them with autism if you feel like they meet the criteria in every other aspect. Some insurance companies may not pay for autism services without the ADOS typically being done. So you may have to refer your patient out for testing, even if you are certain of the diagnosis. There's been several times that I'm like, yes, I know this child has autism. They meet the criteria, but we cannot literally get any of the services for them until the insurance company literally said they have to have an ADOS showing that they meet the criteria, which again becomes problems if they get the ADOS and ADOS does not show, they don't meet criteria per the ADOS, but they meet it with your clinical evaluation. It makes it difficult to you have to fight to get those kids the treatment that they need. So speaking of treatment, let's go through what we can do for children with autism. Now, autism is a neurodevelopmental disorder, so there's not a lot of medication wise that we're going to be expecting for treatment. Most things are going to be structured educational behavioral interventions. And those structured educational behavioral interventions are effective for children with autism. They are associated with better outcomes. Utilizing applied behavioral analysis, or ABA therapy, is basically, ABA therapy is like the gold standard treatment for those with autism, and it's early intensive behavioral intervention for young children. It is highly individualized and very intensive. They can have up to 40 hours per week of one-on-one direct teaching with ABA therapy. And then ABA therapy techniques have been shown to be efficacious for specific problem behaviors and is as effective as applied to academic tasks, adaptive living skills, communication, social skills, and vocalization skills. Community interventions are typically addressed in the individualized education plan with a speech language pathologist. And those who cannot use words yet can be helped through alternative communication modalities such as language communication boards. Those with fluent speech focus on pragmatic language skills training, so learning how to appropriately communicate in social situations. They go to that kind of skills training to help them to be able to communicate better in social situations. As far as educational interventions, these children need a structured educational approach. They need planned, intensive, individualized intervention with an experienced interdisciplinary team and family involvement. And then the goals of the educational interventions is to enhance the verbal and nonverbal communication, their academic skills, and social motor behavioral capabilities. Now, with the structured educational behavior interventions, we may be able to increase their ability to gain benefit from interventions and remain in less restrictive environments through the management of severe and challenging behaviors. Combining medication with parent training is more efficacious than medication alone for decreasing serious behavioral disturbances, and is more efficacious than medication alone for adaptive functioning. So that's what I want you all to take away here, is that, I know a lot of times parents will come into the office and talk about the behavioral disturbances that their child with autism has, but it's not going to be, medication alone is not going to be effective. You also have to have the parent training to be able to help them to the best level of the highest level, because the medications alone aren't going to address that. Now, as far as our clinical pearls regarding this, the goal of psychopharmacologic treatment is to improve the child's adjustment and engagement with educational intervention. We do not want the children to be severely medicated to the point of sedation where they can awake to function in intervention settings. most alternative and complementary treatments. This is another clinical pearl. Most alternative treatments have very little empirical evidence to support their use in children with autism. So any of those, I know some parents get very desperate, and they want to know if giving CBD oil is going to help, or if changing their diet is going to help, or omega-3s, is that going to help. Any alternative treatment options that have been out there have very little support for that. And that's what I tell families. I'm like, if you want to try giving them omega-3, I mean, you can. It's not really going to hurt, but I don't expect it to do anything because the research does not show that they are helpful in autism spectrum disorders. Now, when we're talking about autism spectrum disorders, most people struggle with the aggression of those with autism. Usually that's the most concerning issue, because that's usually what causes all of the problems and most of the issues. And so there are risk factors for aggression in children with autism spectrum disorder. So studies have found that children with ASD engage in aggression to gain access to repetitive behavior. So remember when I talked about, they may really be focused on, lining up objects, or they are focused on, they have to do this thing a certain way, and they have to do it, numerous times. And anytime you interrupt them doing that, usually you're going to have aggression come from that child. Their language ability is a risk factor for aggression in children with autism spectrum disorder. Their IQ, so whatever their IQ is a risk factor, and then their level of adaptive functioning. Now, this is in contrast to typically developing children. So in typically developing children, we see aggression usually in the young age, because they can't communicate their needs as well, so they may act out and have aggressive behaviors. In typically developing children, boys are more aggressive than girls, but there's no sex difference found in those with autism spectrum disorders. And then in typically developing children, their level of parent education and marital status is what is a risk factor for aggression. But the level of parent education and marital status are not consistently predictive of aggression in autism. So aggression treatment, so we have non-pharmacologic treatment and then pharmacological treatment of aggression. So the ABA therapy that I talked about before combines functional behavior assessment and then schedules of reinforcement. So the purpose of the behavior is the desirable consequence the behavior creates, which then causes the behavior to persist. So when they do whatever behavior to get whatever consequence, and then once they get that consequence, they keep doing that same behavior to get the consequence that they want to receive. So when we're doing functional behavior assessment, we are looking at that, and that's going to help us to increase useful behavior, utilizing the information we gather with the functional behavioral assessment. We're going to be able to utilize that to increase useful behavior and reduce harmful behavior. And so with the functional behavioral assessment, we gather data to determine what desirable outcomes are maintaining, what desirable consequences are maintaining the child's behavior. If you do not do this, if you do not figure out what outcome the child is getting with their behavior, you providers run the risk of applying inappropriate treatment and possibly worsening the behavior. And then with reinforcement, so you provide a desirable consequence following a behavior, which increases the likelihood that behavior will happen again. So you want to do differential reinforcement strategies. So based on that, this target, the target problem happens, and then the target problem behavior happens, and then you want to figure out what is making that target problem occur, and you want to stop that so that you change the behavior. So differential reinforcement strategies are efficacious in the treatment of problem behavior in children and adolescents with autism spectrum disorders. And then non-contingent reinforcement strategies. So these strategies are not dependent on if the problem behavior happens or not. They are also effective in decreasing aggression. Now, coming to pharmacological treatment of aggression in autism. The second generation antipsychotics are the most commonly used first line for the treatment of aggression in autism spectrum disorder. So risperidone and aripiprazole, Risperdal and Abilify, have been approved by the FDA for the treatment of irritability, consisting of primarily physical aggression, self-injury, tantrums associated with autism spectrum disorders. Risperidone is approved for ages 5 to 16 years old, and studies show that there is a decrease in irritability, physical aggression, self-injury, and property destruction. The adverse effects of risperidone include weight gain, sedation, somnolence, and excessive appetite. And then aripiprazole is approved for children with autism 6 to 17 years old, and the studies show that it improves irritability. The adverse effects with aripiprazole is weight gain, increased extrapyramidal symptoms, specifically akathisia or feeling restless, and sedation. Now, there are other second generation antipsychotics that are not FDA approved for irritability in autism, and I'll go through those, the different ones, and why. So clozapine has case reports that shows it reduces aggression associated with autism, and it's associated with less polypharmacy, but there are no controlled studies regarding the use of clozapine. Now, the adverse effects of clozapine include constipation, significant weight gain, tachycardia, lower seizure threshold, and agranulocytosis, which requires frequent blood draw for monitoring. And that usually because it's usually difficult to get a kid with autism to understand why they have to give blood and do blood draws. That's why we don't really use clozapine in this population, because it's very hard to get the blood draws that are required, which with clozapine for the first 6 months are weekly blood draws. So we don't use it in this population generally because it's just hard to get the data that we need, the lab values that we need to safely prescribe clozapine. Then we have olanzapine, which studies show mixed results, but that it may be somewhat effective. The main side effects with olanzapine include weight gain and sedation. And so we have to just watch that with olanzapine. And again, it's just mixed results, but may be effective. So, that's one that I really don't even touch too much with those with autism, especially because of the concern of the weight gain and sedation. Ziprasidone, there are no randomized controlled trials, but there are some open label studies that suggest it may be a weight neutral option for autism spectrum disorder associated irritability. But with ziprasidone, you have to monitor for the QTc interval changes and cardiac events, because ziprasidone has a known risk for a prolonged QTc interval. And also a clinical pearl with ziprasidone, it has to be given with meals because the absorption of ziprasidone increases significantly with food. And if it's not given with meals, the patient is probably not getting the adequate dose of that medication, and therefore you won't see any change in the symptoms because they're not getting the amount of the drug that you would expect them to be receiving. So they have to get it with meals, which may be hard to do in a child with autism because they might not want to eat or whatever, and it's twice a day dosing, so it can get difficult with ziprasidone. Then we have polyperidone, which is the major active metabolite of risperidone, and there is limited evidence to suggest that it may be effective and well tolerated as an alternative treatment option for patients who do not respond to risperidone. Since it is a metabolite of risperidone, maybe, for whatever reason, that person's body does not break down risperidone appropriately, but maybe, bypassing that first breakdown step and going straight to polyperidone, that may be more effective for them. Now, lorazepam is not a viable treatment option in this population. One randomized controlled trial showed no improvement in aggression, irritability, and significant adverse reactions. So do not use lorazepam in children with autism. And so in saying all that, clinical pearls, if you're going to prescribe a second generation antipsychotic, you must get baseline labs, especially glucose, hemoglobin A1C, and lipid panel, and follow every 6 months because of the increased risk of development of diabetes and high cholesterol with second generation antipsychotics. You also want to follow weight because with these medications, they can cause significant weight gain. You can utilize metformin to control to help with the weight gain in those that gain weight on second generation antipsychotics. It has been shown to be helpful, but we try to not do polypharmacy as much as we can. But if it's helping and they're having this weight gain issue, then we will want to utilize metformin if we have to. Now, as far as first generation antipsychotic, haloperidol or Haldol is the only first generation antipsychotic with evidence to support use in youth with autism spectrum disorders. There are fewer cognitive effects, less sedation, and fewer extrapyramidal side effects. It shows significant improvement in withdrawal and stereotypy, and there have been positive impact on learning when combined with language training. Now, the adverse effects, the adverse reactions with haloperidol include sedation and dystonic reactions and significant risk of dyskinesias. As far as the anti-epileptic medications are concerned, there's really no significant improvement with the AED medications in the treatment of irritability or target global improvement. Valproic acid is not a valuable treatment option for youth with autism spectrum disorder and irritability, according to one double-blind placebo-controlled trial. Lithium has limited studies that show some improvement in symptoms, but the significant adverse effects were reported, such as vomiting, tremor, fatigue, irritability, and uresis. And so usually those that participated in those studies stopped the lithium because of those adverse side effects. Now, N-acetylcysteine or NAC has shown, limited studies have shown that it can help with a reduction in irritability symptoms alone and as an adjunct to risperidone in those with autism. And then naltrexone, there have not been any robust effects on aggression and irritability, according to research, but they may have an impact on hyperactivity symptoms associated with autism spectrum disorder, according to very limited studies. And I know this was a lot, and there's a lot more that could be addressed with autism, but I feel like, with autism, the most concerning thing is dealing with the aggression and how to treat that. And so that's why I focused on that as far as treatment options. But I utilized the ACAP, the American Academy of Child and Adolescent Psychiatry. They have a resource center regarding autism, and they have a lot of stuff in there on treating different comorbid disorders within autism. And so that is a resource that I tell people about. You don't have to be an ACAP member in order to access that resource center. So there's a lot of information there, and then my other resources. And now we'll share a bit here about the Child Psychiatry Access Network, and then take questions on our topic today.
Thank you very much, Dr. Johnson. Let me go ahead and share my slide. So we appreciate you joining us today for the CME. It is being presented by the Child Psychiatry Access Network. The CPAN program is available to PCPs throughout the state of Texas, all 254 counties. Our CPAN team here at the UT Health Science Center is specifically serving the Northeast 25 counties. This service, and you can see the county breakout here, this service is at no cost to you. And if you are a provider who is not yet enrolled in Texas CPAN, or you are enrolled but not very familiar with our program, we'd appreciate the opportunity to talk with you and your colleagues about CPAN's free psychiatry consultation. So child psychiatry consultation, as well as referral and resource assistance to identify mental health resources for your clinic. Again, this is at no cost. There is a grant provided by the state of Texas. They are very concerned about the state of mental health for children and adolescents across the state, and have funded through Senate Bill 11 nearly $50 million to specifically address children's mental health, and using evidence-based programs to do such. If you have time and would like to know more information, please go ahead and give us a call at the number below, or you can certainly give me an email, send an email to us at the cpaninfo@uthct.edu. If you are interested in having a short presentation about CPAN for you or your team of providers, if you're at a clinic not yet enrolled, we are certainly open to do that. It gives you a time to ask questions, even about specific cases if you're interested. So looking forward to serving you. If you are a PCP somewhere here in Northeast Texas, if you are in a different location, you can call that CPAN number showing at the bottom, 888-901-2726. Choose the region in which you're located and you'll get connected to the team that serves you. All right, Dr. Johnson, I'm going to pass this back to you. So I have one question. Actually, I have a couple of questions in here. So given the significant disparities in the identification of ASD, what advice would you give PCPs to help them better identify signs of autism spectrum disorder in females and racial and ethnic minorities?
So for that question, I think one thing I feel that not just primary care doctors, but providers in general, when we're dealing with identifying signs in females and racial and ethnic minorities, is that we just don't ask enough questions to get the data that we need. So we're not asking, how was this child when they were younger? Like, do you remember any specific behaviors that they had when they were smaller, when they were an infant or a toddler, or even preschool age if they're a little bit older? I think, because I see it a lot of times, that it literally gets missed because nobody asks questions about repetitive behaviors, and nobody literally asks without, like, if the parents didn't just spontaneously provide that information, people miss out on the restrictive, repetitive things that a child might have been interested in or still are interested in, and it's just completely missed. So I think, when you are reading the diagnostic criteria for autism, making sure that you go through and ask all of those questions. Don't skip any of them, because I think when you skip some, that's when or if you wait for the parents to just spontaneously tell you, they may not even remember that was something that happened when they were younger, or even currently they might not even remember to tell you about it because they may not see it as a problem. So you are going to have to look at the criteria and the questions based on the criteria, and I think that would help better identify those signs in females and racial and ethnic minorities.
All right, one more question here. What do you think of the use of repetitive cell phone videos as a calming agent for ASD? They seem commonly used by parents.
For me, like most of us, we probably don't like a lot of screen time for children. But when we're dealing with those with autism, if that is something that has been found helpful, what we need to help the parents with is utilizing it as a tool to help the child remain calm or be calm, but not use it as like that's the only thing. Like, let that be one of the tools in the toolbox that can help calm the patient. But that's part of the reason why engaging in ABA therapy is very helpful, because then we can come up with other tools that are in the toolbox to help calm the kid, and not only deal with the one thing of, okay, the cell phone videos, that's the only thing that we have, so that's what we use, and so the kid is always on the screen all the time. We got to come up with other tools that can be utilized as well. So I think it is okay to use them, but it needs to be one of the tools, not the only tool.
Okay, great. I'm going to attempt to check. Let's see if there are any other questions in here. I don't see any. So I will go ahead, and I have placed the slide for obtaining continuing education credit. As it says on the slide, please use the QR code. You can also access the evaluation at this link, and I will post it in the chat also. And any other questions or anything that we can answer for you today? All right. Dr. Johnson, great job. Large topic to tackle, and we're excited to have your presentation. For those of you who are still here, we are going to have a second part to this from the behavioral health standpoint in June, and we look forward to providing that for you. Watch for the invitations for our May weekly CMEs to celebrate May as Mental Health Awareness Month. Thanks again. Have a great day, and talk with you all soon. Bye now.